Good morning to all. Let us start the session on virus and eye. So why we choose this topic is because the during the COVID period, the virus, how it has affected our daily life and how difficult it was to tackle them. So let us start with some of the diseases which affect the eye, starting from the cornea to the retina. The first talk is by Dr. Jasmine. Madam is Associate Professor GMC Kollam. She will be talking on corneal lesions of herpes simplex. Over to you, ma'am.
Good morning, all. Let me first of all thank Dr. Papa and KSOS for giving me this opportunity. Topic given for me is corneal lesions in herpes simplex. We all know HSV is endemic throughout the world, and it is common cause for unilateral blindness in both developing and developed countries, and is a very common in causing recurrent corneal ulcers. About the virus, it is a double-stranded DNA virus, and it is humans are the only natural host. There are two types of herpes virus, type 1 and type 2. Type 1 is associated with ocular and facial lesions, and type 2 associated with genital lesions. Its clinical manifestations are congenital and neonatal ocular herpes, primary ocular herpes, and recurrent ocular herpes. Congenital and neonatal ocular herpes, it is acquired from genital herpes from mother and 80% by HSV2. Ocular manifestations are periocular skin lesions, conjunctivitis, epithelial and stromal keratitis, cataract, and necrotizing chorioretinitis. By the age of, about the primary ocular herpes, by the age of 5 years, nearly 60% of the population has been infected with HSV, and it causes acute follicular conjunctivitis, keratoconjunctivitis, preauricular adenopathy, and periocular and eyelid skin lesions. Infections are usually mild and they won't reach to the doctor. So, after the primary infection, HSV travels in a retrograde fashion to various ganglia, including trigeminal ganglia, where when the host immunity decreases, reactivation occurs and it causes recurrent infection. So, what we are seeing in our clinics are recurrent infection. Primary infections, usually they won't seek medical attention. And following some triggering factors, they usually cause recurrences like fever, following cataract surgery, some excimer laser, PRP lasers, etc. This is the classification of recurrent HSV keratitis: infectious epithelial keratitis, neurotropic keratopathy, stromal keratitis, and endotheliitis. Infectious epithelial keratitis usually present with pain, photophobia, and watering. The earliest lesions present as multiple vesicles. Within 24 hours, the vesicles turn to typical dendritic or geographic ulcer. This is the typical dendritic ulcer. It is the most common presentation. It causes branching linear lesions with terminal bulbs which contain live virus, and it is a true ulcer. It extends through the basement membrane. It stains positively with fluorescent along the length and at the margin swollen epithelial cells with the rose bengal. And next, if suppose we are treating dendritic ulcer with steroids, it can progress to dendritic ulcer, progress to geographical ulcer. It is also a true ulcer with, it is no longer dendritic linear, it contains swollen epithelial borders with live virus, and it has geographic borders. Another condition is marginal ulcer. It is usually confused with staphylococcal marginal disease. It is more symptomatic and may need topical corticosteroid. sickle. It can cause complete resolution, can cause dendritic epitheliopathy, and stromal scarring like ghost figures and footprints. And 25% can progress to stromal disease. About the neurotropic keratopathy, usually by topical antiviral drops, it will heal by 2 weeks. Suppose the epithelial ulcer is not healing by 2 weeks, you can suspect neurotropic keratopathy. It is neither immune nor infectious. It is due to impaired corneal innervation and combination with decreased tear secretion. It is usually seen in the interpalpable region, round or oval shaped ulcer. Next is the stromal keratitis, two types, necrotizing stromal keratitis and immune stromal keratitis. Necrotizing stromal keratitis by the direct viral invasion, the clinical features are causing ulceration, necrosis and dense infiltration of the stroma with overlying epithelial defect. The severe inflammation can lead to thinning and perforation. It can mimic microbial keratitis. So you should suspect a microbial keratitis with. Otherwise, we will miss it. When will you suspect? That is due to chronic history, recurrent episode, granular whitish infiltration with epithelial defect, minimal discharge and slough, vascularization, corneal sensation is decreased, footprint scars, atrophic iris atrophy, no photophobia, not very symptomatic. If pain is present, it may be due to uveitis. So, whenever the patient comes, patient will be asymptomatic due to the decreased corneal sensation. Immune stromal keratitis, it is the chronic recurrent manifestation due to the retained antigen. There will be, epithelium will be intact and the stromal infiltration may be focal, multifocal and diffuse. Usually you get neovascularization and ghost vessels. Next is the endotheliitis. The target of inflammation is the endothelium, which causes endothelial dysfunction. There won't be stromal infiltration. Other findings are keratic precipitates, overlying stromal and epithelial edema and iritis. 3 forms are there: disciform, diffuse and linear. Disciform is disc-shaped distribution in the central part with overlying keratic precipitates and overlying stromal edema. Another one is the diffuse. The keratic precipitates may be distributed throughout the endothelium. And next is the keratic precipitates. It's line of keratic precipitates from the limbus to the central area. Thank you.
Thank you, Madam, for the nice presentation. Next talk is by Dr. Susan Philip. Madam is Associate Professor R.A. Trivandrum. She will be speaking on viral glaucomas. Over to you, ma'am.
A warm good morning to one and all. And at the outset, let me thank Dr. Papa for giving me this opportunity, and we are very happy to have a keynote speaker with us. So my topic for today is how glaucoma is associated in viral diseases. So let me first present it to you a patient who has come to us, a 28-year-old male patient who is a painter by profession, came to our clinic with a history of conjunctivitis 3 months ago, which was treated elsewhere. His present complaint was a dull ache in both eyes with blurry vision. His eyes were white, but he had multiple subepithelial opacities in both corneas, and his vision was 6/6 blurred in both eyes. Intraocular pressure was 28 millimeters of mercury in right eye and 30 in left eye. Cup disc ratio was normal. He gave history of using lotiprenoid eye drops for subepithelial opacities for the last 2.5 months. His intraocular pressure returned to 12 and 14 after we stopped lotiprenoid, and initially he was treated with anti-glaucoma medication. So steroid drops were the villain here, as he may be a steroid responder. So when you treat a case of subepithelial opacities due to adenoviral infection, monitor the intraocular pressure and use steroid drops judiciously. But in acute adenoviral infection, if the intraocular pressure is high, you must suspect an associated trabeculitis and will need judicious use of topical steroid drops, close monitoring of intraocular pressure, and if it is elevated, it must be controlled with anti-glaucoma medications. So what is the relevance of this topic? When Papa gave me this topic, I was wondering what to say. The ocular manifestations and sequelae of viral infections are not well understood. In fact, the association of viruses with glaucoma is considered relatively uncommon, in part due to underreporting and due to lack of long-term follow-up studies. So recent literature on emerging viral infection, especially in Zika virus and our COVID virus, has shown association of glaucoma with ocular viral infections. Renewed research activity in this, especially in endemic regions, is the need of the hour. So I have listed a few common viruses which are associated with pathogenesis of glaucoma. And how does the virus enter? It either through the direct entry, or it can be through from the systemic circulation by the breach in the blood-retinal barrier. So as we know, the viral infections can cause glaucoma either due to trabeculitis, inflammation of the trabecular meshwork, or by the infiltration of the inflammatory immune cells like polymorphonuclear leukocytes, etc. in the trabecular meshwork or Schlemm's canal, or by release of pro-inflammatory cytokines, enzymes, reactive oxygen species, leading to glaucomatous changes. So viral uveitis can either present as an acute onset as in herpes simplex virus, it can be chronic as in rubella virus, or both acute and chronic is seen in cytomegalovirus infection. Cytomegalovirus infection and Ebola virus infection can cause posterior segment pathology, mainly in immunocompromised individuals, which can also cause secondary glaucoma. So herpes viruses are the commonest which produces are the commonest viral infections, and those are the ones which causes glaucoma commonly. And in that group, we have herpes simplex virus, varicella zoster virus, and cytomegalovirus. Usually, herpes viruses, almost all of us will be having herpes, can have herpes simplex virus in our body, and those who have had chickenpox definitely has varicella zoster. So glaucoma is the commonest complication of herpes virus ocular infection. So herpes simplex 1 is more commonly associated with glaucoma. Following primary infection, HSV establishes a latent infection in the trigeminal ganglion or the sensory nerve ganglion, reaches the neural axons, causing inflammation and diseases in the periocular, corneal, and intraocular areas. The existing literature and clinical presentation establish a strong link between HSV infection as a significant cause of anterior chamber uveitis and consequent development of uveitic glaucoma. Varicella zoster virus, unlike HSV uveitis, has an acute recurrent cause. Typical facial lesions, vesicles, rashes are seen, and varicella zoster almost always manifest unilaterally. Cytomegalovirus is commonly seen in immunodeficient individuals as in HIV patients, and it causes trabeculitis, ocular hypertension, while in acute cases, and in chronic cases, increased intraocular pressure is due to restricted aqueous outflow through damaged trabecular meshwork following chronic inflammation. I don't know whether you can see the pigmented KPs are seen in the periphery, and the second picture, if you see, you can see typical coin-shaped KPs in the center, which is typical of cytomegalovirus. Cytomegalovirus can also cause glaucoma in immunocompetent patients also, because it may present as a recurrent acute or chronic inflammation, and Posner-Schlossman syndrome and Fuchs heterochromic iridocyclitis, as in many literature, it has been reported as patients had cytomegalovirus, their aqueous tab was taken, and cytomegalovirus has been isolated from that. So Toga virus causing glaucoma includes chikungunya and rubella virus. Chikungunya we have had many episodes of chikungunya in Kerala. So in few cases have been reported with uveitis following chikungunya virus. Rubella virus typically presents with congenital rubella syndrome, which has many associations along with congenital glaucoma. Rubella commonly affects the younger age group, and it induces glaucoma, is associated with dysgenesis of the anterior chamber angle. In addition, inflammatory components, early extraction of cataracts, and necrosis of ciliary body and trabecular meshwork are the other contributing factors for rubella-induced glaucoma. Filoviruses causing glaucoma includes Ebola virus. We have not much literature in India about that. Ebola virus induced uveitis was either bilateral, anterior, or pan-uveitis. Cases of glaucoma, cataract with glaucoma, and corneal scar with glaucoma were seen among those with Ebola virus disease. These are the flaviviruses causing glaucoma: dengue, West Nile virus, hepatitis virus, and Zika virus. Dengue virus induced ocular complications include paracentral scotoma, blurred vision, retinitis, etc. But anterior uveitis and glaucoma also has been reported. Despite the paucity of reports, dengue virus induced uveitic glaucoma is a potential, because it's a potential virus agent with ocular tropism. That is, it has an affinity towards the eye, and there is a need for study to see whether it is associated with glaucoma. So West Nile virus is not seen in our place, but anterior uveitis is also associated with that. Hepatitis virus is very rare in causing glaucoma, but there have been case reports by all hepatitis A, B and C causing glaucoma. And now Zika virus has produced a Zika virus syndrome with most dramatic manifestation is microcephaly. Congenital glaucoma is associated with Zika virus infection. And our coronavirus, we have all had anterior uveitis patients who had corona. And as we all know, sadly, actually ophthalmologist first reported about coronavirus, some strange virus, while he was treating a glaucoma patient, and sadly he lost his life. I mean, the ophthalmologist lost his life. So my take-home message is timely identification of the infectious etiology is crucial for prioritizing and managing the disease. Therapies aims at inhibiting or fine-tuning intraocular inflammation and inhibiting specific immune cell infiltration could be the next generation choice of treatment for managing virus-induced ocular pathologies. Thank you.
Thank you for the wonderful talk, Susan. Now I call upon Dr. Papa for her talk, Viral Retinal Mysteries.
So from the anterior segment, now move on to the posterior segment. So let us see some of the common viral retinal lesions. The most common being the herpes virus retinal lesions. It can produce acute retinal necrosis. It can be produced by both HSV and HZV. Usually seen in immunocompetent, and 70% of cases are unilateral. The retinal necrosis starts from the periphery and spreads in a circumferential manner and causes occlusive retinal arteritis, and severe vitritis will be there. The prognosis is good if you treat early with intravenous antivirals, but 70% of the cases develop retinal detachment. Next is progressive outer retinal necrosis. The difference is that it usually comes in immunocompromised persons. Both HZV and HSV can cause. And usually it affects the posterior pole and involves the macula. It has got a fulminant course and causes bilateral blindness and no vitritis because it is immunocompromised patients. And prognosis is better with intravitreal antivirals. Not much response to systemic antivirals. So this is the difference. So you can see in ARN starts on the periphery, but PORN is mostly in the posterior pole, and more of vitritis and hemorrhages you can see in acute retinal necrosis. So this is a table which shows that acute retinal necrosis is usually associated with anterior uveitis and scleritis. So patient may have pain also, and it is it causes occlusive vasculitis. The other one is no vasculitis. Next is the cytomegalovirus. It's usually seen in HIV patients if the CD4 count is less than 50. And nowadays the incidence is low because of the effective antiretroviral therapies. Mainly 3 types. It can cause frosted branch angiitis, that is phlebitis, granular type, and necrotic. Necrotic is said to have a more aggressive course and it can produce retinal necrosis and detachments. Granular is the least aggressive form. The differences between ARN from CME is again ARN is in immunocompetent and affects the peripheral retina, and it is occlusive arteritis, while in CME it is more of phlebitis, and vitritis is more in ARN but no vitritis in CMV and less hemorrhages compared to CMV in AR. Epstein-Barr virus, not a common virus, but it can produce an ARN like acute retinal necrosis like picture. It can produce panuveitis and frosted branch angiitis. Now the COVID-19, the retinal lesions are seen in infected persons as well as post-vaccination. The common presentation is it can produce a multiple evanescent white dot-like syndrome. So you can see the white dots distributed more in the peripapillary area, and it is usually unilateral. It is due to inflammation and response to steroids also. Because of the hypercoagulability in COVID patients, the major vascular accidents are common like CRVO and CRAO. And even vaccinated individuals can have these kind of vascular accidents. So the third picture shows a supratemporal branch retinal artery occlusion. It is seen in a vaccinated person, not an infected person. Next is this PAM, paracentral acute middle maculopathy. It is actually the hypercoagulability which causes ischemia of small vessels, that is a deep retinal plexus. So what you can see is a paracentral area hyperreflective of the reflectivity of the inner layers of the retina, and it can cause paracentral scotomas. Patient will have scotomas. It can be vaccine or infection related. Next is the acute macular neuroretinopathy. This is also ischemia of more deeper, that is choriocapillary layer. Patient will have hypopigmented wing-shaped areas in the foveal area, and patient will experience a paracentral scotoma and defective vision. And the octa shows, you can see the octa showing some areas of capillary non-vision in the choriocapillary layer. All the patients, all COVID patients need systemic steroids, so it can cause CSR. Fungal endophthalmitis, it is common in immunocompromised patients and also in diabetic patients. Next common virus is the dengue. Because of the thrombocytopenia, it can cause massive retinal hemorrhages. It can cause panuveitis-like picture or multifocal chorioretinitis, and usually the prognosis is good. Dengue is famous for the macular lesions. It can cause dengue maculopathy. It can be a macular hemorrhage, or it can be a diffuse or cystoid macular edema, or it can produce a fovealitis, we call as AMN, or a PAM-like picture. Patient will have scotomas and defective vision. West Nile virus, not very common. It can cause multifocal chorioretinitis, and the diagnostic tool is that these chorioretinated patches are arranged in a radiating pattern from the disc along the nerve fiber layer. That is the diagnostic tool, and it can cause retinal vasculitis also. HIV, again, it can cause microangiopathy, which presents as cottonwool spots and hemorrhages. It can be associated with CME retinitis, and even the varicella zoster and HSV infection can be seen in HIV patients. Other viruses in children with SSP, that is subacute sclerosing panencephalitis, they may have retinal necrosis which affects the macular area. So the children will have defective vision. This may be the first sign of SSP also. Rubella virus, it affects the fetus in utero, and the child is born with salt and pepper retinopathy. Even adults can have a rubella virus infection. Chikungunya, it causes multifocal chorioretinitis, and it is treatable, and Zika virus also causes focal chorioretinitis. So these are some of the common lesions. Thank you for the patient hearing.
Thank you, Papa, for that wonderful presentation. The pictures were really good. Now it is my pleasure to invite Dr. Nimmi, Assistant Professor, RAO Trivandrum, to present her topic on investigations and management of ocular viral infections.
Good morning, all. I'm thankful to Dr. Papa and KSOS for giving me such a great opportunity to present in this prestigious conference. My topic is how to diagnose and management of the viral diseases, the taming of villains. First of all, let me talk about the herpes simplex keratitis. As Dr. Jasmine has already mentioned, there are various types: epithelial keratitis, stromal keratitis, and endothelial keratitis. In epithelial keratitis, It is diagnosed clinically. The characteristic dendritic pattern is there, linear dendrites with, what we can do is staining with rose bengal and fluorescein dye. That is double staining. Rose bengal will take up the margins, at the margins of the ulcer, and fluorescent will be stained at the base of the ulcer. In very rare cases, you can do a corneal scraping in atypical cases. Treatment is basically with topical antivirals, that is, you can give topical acyclovir 3% eye ointment 5 times daily, or even ganciclovir gel is available, which can be given 3 times daily. And it has to be continued till the staining becomes negative. Oral acyclovir, oral antivirals are not indicated in epithelial keratitis. Stromal keratitis, it is without ulceration. Topical steroid is the mainstay of treatment. It can reduce the stromal inflammation and shorten the duration of the course of illness. And here you can give oral antivirals in the prophylactic dosage, that is oral acyclovir 400 milligram BD or valacyclovir 500 milligram OD. Here you can give topical antivirals. As we are using topical steroids, we can use topical antivirals to prevent epithelial keratitis. In necrotizing stromal keratitis, therapeutic dose of oral acyclovir is given, that is 800 milligram 5 times daily for the first 7 to 10 days, followed by the prophylactic dose. Topical corticosteroids are given once the epithelium heals. In endothelitis or disciform keratitis, again oral acyclovir is given in the therapeutic dosage, that is 800 milligram 5 times daily. There are other options as well, and you can give topical corticosteroids. Apart from these, you can give adjuvant therapy like cycloplegic and AGM whenever needed. So there are a few indications of oral antivirals in herpes simplex keratitis. It is given to prevent scarring and to maintain viral latency, and also to prevent recurrence. So there are the specific indications are more than 2 episodes of stromal keratitis a year. There are multiple scars on the cornea and lesions involving the visual axis, endothelitis, and patients undergoing ocular procedures like keratoplasty, cataract surgery, and ocular procedures, other laser procedures, and in immunocompromised patients. So these are the drugs that are given for antiviral prophylaxis. Acyclovir 400 milligram BD, valacyclovir 500 milligram OD, and famciclovir 250 milligram BD. The optimal duration of prophylaxis is not fully established, but for at least 1 year it is recommended. Neurotrophic keratitis, the aim of the treatment is to promote epithelial healing. So we can give generous use of lubricants, autologous serum, and patching, and finally you may have to do tarsorrhaphy to promote the epithelial healing. Coming to more commoner, adenoviral keratoconjunctivitis, again the diagnosis is clinically, we are doing it clinically, clinical diagnosis. Certain tests like rapid adeno detector, PCR, viral cultures are all available but not routinely used. Treatment, it is self-limiting within 2 to 3 weeks. It may resolve without any complication. You can start on lubricants and topical antibiotics to prevent secondary bacterial infection. In acute phase, topical corticosteroids, it is controversial. Indications include the presence of pseudomembranes, subepithelial infiltrates in the visual axis, and severely symptomatic patients with severe lid edema, photophobia, chemosis, etc. Disadvantages of using topical corticosteroids, the lesions may recur on stopping the steroids, and long-term side effects can occur like cataract and glaucoma can occur. So it has to be discontinued. And in some certain studies, it has shown that povidone iodine along with topical dexamethasone may be useful. Maybe you can put it in a single setting or multiple settings. In steroid non-responding cases to steroids, you can use topical cyclosporin or topical tacrolimus. So coming to the posterior segment lesions, the treatment, Viral retinitis is common, and acute retinal necrosis, the characteristic features are there. So it is also a clinical diagnosis. You can see the peripheral necrotic retinitis patches along with vitritis, occlusive arthritis and all. And you can do an aqueous or vitreous tap, send it for PCR, and very rarely you can do an endoretinal biopsy. Treatment is basically with systemic antivirals, intravenous acyclovir 10 milligram per kilogram, Ethali for 10 to 14 days. You have to give as an induction dose and followed by a maintenance dose of oral acyclovir 800 milligram 5 times daily for at least 3 months. In unresponsive cases, intravitreal injections like ganciclovir or foscarnet can be given, which have to be repeated 2 to 3 times a week, and systemic antivirals to be continued along with the intravitreal, and after 24 to 48 hours you can start them on corticosteroids. ARI has got a high rate of retinal detachment. You can do a prophylactic laser, but it is controversial. And those who develop RD, you may have to do PPV, though the poor visual outcome is very poor. Extended antiviral therapy may reduce the incidence of contralateral disease by 80% over 1 year. In progressive outer retinal necrosis associated with HIV infection, CD4 count less than 50, combination of intravitreal ganciclovir along with intravitreal acyclovir is found to be useful. They may need long-term maintenance and antiretroviral therapy. CMV retinitis, again it is a clinical diagnosis. PCR can be done with aqueous or vitreous tap. Treatment, intravenous ganciclovir is the drug of choice, and maintenance of oral valganciclovir. Along with intravitreal ganciclovir in vision-threatening lesions. It can be stopped in HIV patients with good immune recovery after 6 months, ART naive patients only for 6 months if there is good immune recovery, and ART experienced patients long-term maintenance therapy is needed. EBV retinitis is similar to ARN, and systemic acyclovir is the drug of choice. Key takeaways: you can diagnose a clinical viral retinitis by detailed history and thorough clinical examination. Initiate antiviral therapy without any delay. Do not wait for lab investigations, and close monitoring and long-term treatment is needed for these patients. Thank you.
Thank you, Nimi, for enlightening us how to tame the viral infections by proper investigations and the correct treatment to be given. Now it's our privilege to invite Dr. Anil Radhakrishnan, our keynote speaker. He has completed his MBBS from Calicut Medical College and his MS from RIO Bangalore, and he has fellowship in LVP. He has a lot of national and international publications, and he has started many surgeries, corneal surgeries first in Kerala. So it is our privilege to have him here. And more than that, personally, I can say if I have a corneal patient, I am very confident. If I send to Dr. Anil, it will be taken care of properly. I have had many experience. Over to you, Dr. Anil.
Thank you, ma'am, for the extremely kind words. I really appreciate. And thank you, Dr. Papa, Jasmine, ma'am, and Susan, ma'am, for giving me this opportunity. It's really a privilege. So I think some of the facts have already been covered, but it will not be a very comprehensive overview. But I think I'll try to touch upon the main points regarding the varicella zoster, which is a very common clinical situation that we face. So varicella zoster, as we mentioned multiple times in the last 3-4 talks, it's a double-stranded DNA belonging to the herpes group of viruses. So the chickenpox virus is the thing that remains dormant in the ganglia, and it gets reactivated. So now the prevalence of varicella zoster for some reason has increased, and now the shingles vaccine has also come. I'll touch upon that later. So varicella zoster, or more commonly called herpes zoster ophthalmicus, is a common presentation. Trigeminal nerve is the one is usually involved. And varicella zoster accounts for about 10 to 25% of all zoster infections. And the notable thing is that up to 50% will have ocular complications. It varies between 40 to 60%. So if you have increased age, if you have immunocompromised state, if you have impaired T cell immunity, so a lot of people who take chemotherapy, BMT and all that, they take the varicella vaccine to prevent this happening. So it comes to you. Usually it will not come. It will come to you with the ocular complications. It will usually come to you with the conjunctivitis. But if the patient complains of severe pain in one side of the head, you should look for small vesicles like this. So prodrome will be in the first 2 to 3 days. They will be having tingling and pain sensation. Hypersensitivity is the important thing. So you have to closely look at the lids and look for smallest vesicle. And if you have vesicles in that dermatome distribution, it's very likely that it is varicella zoster infection. So I think there is a progression of the vesicles that come. First the macules come, then it became vesicles, then becomes pustules, ulcerate, and then crust. And once it crusts, the infectivity will go down significantly. Till that time, it is infective. And you should also understand that if you have patient comes in at this stage also, if the treating doctor or the optometrist have not had a chickenpox, it is likely to cause chickenpox. So this is something that we have studied so very well in our post-graduation, Hutchison sign. If the side of the nose or the tip of the nose is involved, eye is very likely involved. So initial picture is the blepharoconjunctivitis, in which you have severe blepharitis and this conjunctivitis. So it can cause depigmentation, scarring, trichiasis and all that. So even though quite a lot of people come with severe lid edema, you just have to give supportive treatment. That is, the important thing is you have to start systemic antiviral as soon as possible. If you start within 48 hours, the chance of complications are significantly reduced. So if you look at the literature, acyclovir eye ointment actually need not be given. You just have to give lubricants. The thing is, at this point of time, there will be intense discharge, and there will be the corneal sensation also. It will not be compromised at that point of time, but they'll have pain because of that. So it's better to give good lubricants, and to prevent a secondary infection, to give an antibiotic ointment. Ointment is always better. So in the first week, that is in the first few days, punctate erosions can come. Then the classical dendrite, I think the previous speaker was mentioning, and this is a pseudodendrite. It's a stuck-on appearance like this. So in contrast to HSV, there is no terminal bulb. But I think that is more for a theoretical description. When you see the stuck-on appearance is very commonly seen. But this is a patient, well-known patient. He had a well-proven varicella zoster virus, and he had this branching pattern also. It is not a classical terminal bulb, it looks very much like a terminal bulb. So don't go too much into that. But it has a characteristic stuck-on appearance. In contrast to an HSV dendrite, which has a more branching pattern, and terminal bulbs are very well seen. So this is another patient in whom we have a dendrite. This is more like a pseudodendrite. It has a tapering end. So this also can be seen. This picture is also seen. So first week you will have the dermatology. It's important to have dermatology consultation. But the one important thing is dermatologists usually give this antivirals only for 5 days, which I feel is inadequate. So we have to give it for at least 1 week. I usually give for about 10 days, because if the corneal manifestations or uveitis come, you have to give for a longer period of time, usually about 2 weeks. So till the patient comes to you for a review after a week, you have to give the patient antiviral treatment. So other manifestations that is seen in the cornea is anterior stromal infiltrates. If it is peripheral nummular keratitis, you really don't have to go behind and treat it. Because the varicella zoster uveitis is very sensitive to steroids. There is a high tendency for steroid dependence. So if you can avoid steroids, it would be great. If it's a very mild anterior chamber reaction, you can actually avoid steroids. Same thing with the anterior stromal infiltrates and nummular keratitis. If it's peripheral, you really don't have to start steroids. You have to just closely follow up the patient. But sometimes you can have very severe immune stromal keratitis like this. You have uveitis along with a stromal edema and a picture like this with a lot of keratic precipitates, in which case you have no other option but to give steroids. Anti-uveitis, I made a mention. This keratouveitis can be very mild, usually happens in the first week. It can be very severe also. Sometimes people will come with severe pupillary fibrin and almost looking like an endophthalmitis. And hypopyon also can occur. So this uveitis can really be prevented if you give systemic antiviral agents early in the period. So rarely it can be granulomatous uveitis also. Sometimes iris atrophy can occur and there can be occlusive vasculitis. Madam was previously mentioning about secondary glaucoma. In both herpes viruses, trabeculitis is a common complication. Then on its own it can cause elevation of intraocular pressure, and for trabeculitis, IOP elevation due to trabeculitis, you have to give steroids. The other causes of secondary glaucoma is peripheral anti-racemic A, pupillary block, then steroid-induced glaucoma also can occur. So some of these manifestations can come in a later stage, episcleritis or scleritis, or which is usually diffuse scleritis or a nodular scleritis. Sometimes it can be associated with peripheral ulcerative keratitis also. This is not because of the viral multiplication, this is actually because of there are viral antigens and there is a granulomatous inflammation accompanying that. So you have to treat it with steroids. So there is a debate whether you should give antiviral cover also, but I think most people will give antiviral cover also. You give valacyclovir again for about 1 week, then followed by 500 milligram once a day for a longer period of time. If you have episcleritis alone, you just have to give topical steroids. You don't have to give antiviral agents. Rarely you can get sclerokeratitis and disciform endothelitis. This is a patient we had who had a disciform endothelitis. That was the presentation of varicella zoster. So this is the corneal thickness is severely increased in the central area. You can see a lot of guttae, pseudo-guttae in the central area along with Descemet's membrane folds. So this patient after treatment had a picture like this, multiple areas of iris atrophy. That is because of the occlusive vasculitis that happens in varicella zoster. This can happen in herpes simplex virus also. And more importantly for us, it causes damage to the endothelium. If you look at the endothelial count, the count in a 40-year-old patient has gone down to 1,271 in one eye, other eye it is 2,056. So it causes damage. Immune stromal keratitis can sometimes even come after 1 year. So again, the treatment is basically steroids. Episcleritis, scleritis, immune stromal keratitis, uveitis, everything the treatment is steroids, and you should not be hesitant to start steroid therapy, either dexamethasone or prednisolone acetate. But it is wiser to give an antiviral cover whenever you do that. There are other problems also that can occur, rare complications. Third, fourth, and sixth nerve palsy can occur because of the vasculitis. Horner syndrome can occur, retrobulbar neuritis, very rarely orbital apex syndrome, meningoencephalitis, ARN and PORN, the previous speaker was mentioning about. These are rare, but I think it is very important to follow up the patient after 1 week and within second week also, because most of the complications will happen within the second week. So by second week, you should actually dilate and see also and look for optic neuritis. So neurotrophic keratitis is almost always universal. There cannot be a varicella zoster virus and no neurotrophic keratitis. Quite often it will be very few punctate erosions like this, but sometimes it can take a more severe form. The epithelium can be very unhealthy. You can see the lusterless cornea here with a central epithelial defect. And sometimes in the same patient, a secondary infection has occurred because the immune mechanisms on cornea is not effective. So the aim of medical management is to accelerate healing and to limit the severity and reduce the complications. So the classical antiviral therapy is 800 milligram 5 times a day or valacyclovir 1 gram 3 times a day. It is generally given for 10 to 14 days. I think you can make a call within 1 week. So after 1 week, when you call back the patient, there are no corneal complications, maybe you can reduce, within 10 days you can stop it. Other drugs are also there. Ibs-aceclovir, sometimes we use it. Neuralgia can occur and post-therapeutic neuralgia is also there. Why it is going like this, I don't understand. The management, the neurotrophic keratitis, the management, you have to give it copious lubricants. I think autologous serum is something very useful to prevent epithelial breakdown and possible secondary infection of the neurotrophic keratitis. So these are the sequelae that you see. Rarely you get interstitial keratitis, which can cause lipid keratopathy. So if you see that the deep vessels are there and the lipid is starting to come, as you see in the first picture, then at that point itself, you follow up the patient. If it is increasing, before it gets to the center, like in the second picture, do a treatment for that. So you can do fine needle diathermy of the deep vessels. That is one thing. You can give topical steroids are useful in the long term, but you can't give it for a long period of time. So in the initial phase, Avastin injections are also useful. Subcameral injections are helpful, though I don't have personal experience. The other sequelae is post-therapeutic neuralgia. It can be an acute neuralgia, subacute, or post-therapeutic neuralgia. So there is something called a haptic phenomenon. That's a crosstalk between the adjacent nerves. So you have this pain-carrying fibers, you have the touch-carrying fibers. So when you lose myelin, they crosstalk, and that's why that hypersensitivity occur. So this is a patient who had herpes some time ago, came with redness, and vision was 618. As you see, the eye is looking like there is an ulcer right in the center and a very unhealthy epithelium. But the corneal sensation was absent in the patient. So the patient had a neurotrophic keratitis with secondary infection, took the corneal scrapings. After treating with antibiotics, it settled down, but again, that area, it is without sensation. So you have to think of something which basically improves the corneal sensation. So I'll be showing a short video of the corneal neurotization that can be done. Neurotization means you take the nerve, a sural nerve graft, anastomose to the opposite side supraorbital nerve, bring it to the affected eye, split the nerve vesicles into multiple places and put it down to the cornea. So the corneal nerves will grow into that and restore the corneal sensation. I'm actually ashamed to show this one because I had the video file and it got corrupted, so I had to download something and use it, which gave heartburn to Dr. Papa in the morning. This video, is it running? Can you click on that? So this is the opposite side. You bring the sural nerve, bring it to through the supranasal fornix or supranasal fornix. Then you can, that is a sural nerve graft. So there is a epinurium which you can easily split it. Next slide. And video also should run. Yeah, can you click on the video, please? So if you see it under microscope, all these nerves will have multiple fascicles. So you can actually very easily separate it. I think for people doing microsurgery, it's very easy compared to plastic surgeons. Can I take 2-3 minutes more? Yeah. So we can split it into multiple fascicles and bring it all around the limbus and make maybe 5 or 6 corneal tunnels and put into these corneal tunnels and suture it there. It's important to suture it there, otherwise it will come off. I think compared to plastic surgeons, we can do it better because we can use the crescent knife. Just go 1 to 1.5 millimeter, insert that and put a suture over there. Next slide, please. And the video also. So it's important to bring it all around the limbus, and because only if you do otherwise, that area, the sensation will not be there, or it will take a much longer time for the sensation to come. So you do that in 5 points. or 6 points. Then the sural nerve is anchored to the other nerve. Actually, they suture the perineurium. And for end-to-end anastomosis, you can actually use a fibrin glue. That is done by the plastic surgeon. They do it. Okay. So this patient had a neurotization. After some time, I think the surface was appearing better. So if you look at here, you can see the nerves and you can see the suture over there. So you'll not see any nerves growing actually, because beyond that the myelin sheaths will not come. So we cannot see that, but over a period of time the sensation will become better. It will take at least 3 months. So initially the sensation will come in the forehead. So if you put the eye drops, the patient will feel the sensation in the forehead. Then gradually it will come into the eye. So it will take at least 3 months. So post-operative period, I think the corneal surface was much better. Another patient who had a corneal neurotrophic keratitis, in whom after multiple injuries like that, I did a neurotization and the surface was okay. I'll just touch upon post-herpetic neuralgia. This is actually very common in older age group. So it is not our cup of tea. We have to send it to the neurologist and they will treat it. Nowadays we have so many things that are available, especially gabapentin and pregabalin, which are used. And I think they have a customized protocol for treating it. So I would like to conclude saying that varicella zoster is a very important disease and it has a very varied presentation, and it is potentially life-threatening, vision-threatening if you don't treat it properly. But if you detect the disease early and manage the complications early in the disease process, most of the vision-threatening complications can be taken care of very well. Thank you so much.
Thank you, sir, for the wonderful presentation. Any questions? So how many cases you have done, sir?
I've done only 3 cases, ma'am.
3 cases. All have good results.
Yeah, so one is a patient with this one, with varicella zoster. Other 2 were trigeminal palsies, secondary to, like they had a neurosurgery for cerebellopontine angle, some tumor, and because of that they had a fifth nerve palsy. So it is actually I think the ophthalmologist part is pretty easy. Only thing is we have to spend that time and go there. It's not a very demanding operation at all. People doing microsurgery, even SICS, like it is so easy for you to do. It's just that you have to have that mindset and you have to dissect the perineurium and put it into the cornea and put 4 sutures. It's technically very, very simple.
Permanent cure? No.
It is permanent cure. The important thing is you have to check the sensation in the other eye. We can do a nerve conduction study, or we can even check the sensation with a cotton wisp and see. That is also important.
Very nice, sir. Thank you.
Dr. Anil, how long will you continue valcyclovir and if the patient is having severe scleritis secondary to
Okay.
herpes
So
zoster?
immediate, like the first 10 to 14 days you have to give full dose. That is 1 gram 3 times a day. Then you give a maintenance dose. So if you have scleritis or some complications which are immune related also, there is some amount of viral antigens there. So we have to give some antiviral cover to suppress the virus, or else it might progress. So you can usually, I think it is recommended to use it for 3 to 6 months, ma'am.
Do you give steroid along with it?
Yes. So systemic valacyclovir along with the topical steroids, prednisolone or dexamethasone. Then once you complete 2 weeks, you can go to once a day. That is a prophylactic dose. 500 milligram once a day is enough.
I think we have come to the last of the session. Thank you all for coming the early morning session. Thank you very much.